My name is Bryan Burt. I'm a thoracic surgeon at UCLA, and I'm here today on behalf of the Journal of Thoracic and Cardiovascular Surgery to interview a legend in our field, and that legend is Tommy D'Amico. Dr. D'Amico is the Gary Hock Distinguished Professor of Surgery, a professor and vice chairman of surgery, chief of the section of general thoracic surgery, director of the training program in thoracic surgery, and chief medical officer of the Duke Cancer Institute. Thank you, Dr. D'Amico, for spending time with me today. So our discussion will occur in about 3 different portions. We'll talk about writing, we'll talk about editorial boardsmanship, and then about surgical innovation. So I think it's fair to say that the art and the practice of writing is what distinguishes academic surgeons. And Dr. D'Amico, you're a prolific writer. You've authored at least 440 publications, at least 74 articles in the JTCVS. So I figured we'd spend a few minutes talking about your approach to writing. And perhaps we can try to highlight a few elements that'll be useful for aspiring authors in the field. My first question is about your research contributions. They've been very opportune, very timely, and very high impact. They've addressed what now seem like obvious gaps in thoracic surgery. So when and how do you identify and develop ideas for a research project?
Thank you, Brian. I appreciate your comments. I think the ideas that we've written upon are generated continuously, and they may be ideas that come up at lab meetings. A resident might ask me a question, do I know this? And then I can say it hasn't been studied. I might get an idea, perhaps in the middle of the night, or at that time, maybe in the middle of a transplant. If the evidence is not in the literature, it's something that we're interested in. As you said, if it's a gap, it's something that we're interested in. There have been different levels of study that we've done. Some have been big data studies, either from the National Cancer Database or other databases. Some have been original studies from our own Duke database. Some have been editorials. Some have been responses to other things in the literature that we thought we could make an impact on. But I've always enjoyed it. I've always enjoyed writing. I've always enjoyed the process of thinking about how to better express ourselves, both scientifically and linguistically, for the most impact. I've always enjoyed working with residents. When I have the opportunity to do that, I've written some things on my own.
You've served, I think, on every NCCN panel for every thoracic malignancy, and you're an avid contributor and participant in the AATS. Do you find inspirations in participating in those meetings?
I think it's electrifying. It's helped in many ways. Being on the panels, especially the NCCN panels, we know the data. Everybody on the panel knows that we talk about it all the time. Every time there's a new study, it's part of our everyday discussion. So it's an advantage to kind of be one step ahead. We would know the studies before their data. But I enjoy the process of looking at new studies, determining their validity, and determining how they fit and how they'll change practice. Is this an addition? Will this change practice? Is there enough evidence for it to change practice? So I've always enjoyed that process.
As a writer, a primary author, what's your approach to a blank page?
It's a good question. So it depends. If I'm writing, I love to write commentaries to other JTCVS articles. So I enjoy it when someone says, can you write a comment on this? It's because I have to look at it in a different way than a reader does. How do I illuminate the important parts of what's there, and how do I cast the correct light on things that we have to be guarded of. That not just because the author says something doesn't mean it's true. If the author makes claims that the literature shows somewhere else has already been disproved. That has to be brought to light by the commentator. So it depends on the process. So for an original article, something from our data, something from our lab, the study started from some gap that we identified, and translating that into 1,800 words or whatever it is, I think is a great process. So when I start the blank page, I start with the abstract. I just write the abstract, even if I don't have all the data, and make sure that it comes across as hypothesis-driven, that it isn't a fishing expedition, that we don't derive the hypothesis retrospectively from the answers, that the results are represented clearly without having too much or too little, and that there's nothing in the abstract conclusion that isn't somewhere in the abstract. And we don't end the abstract with larger studies must be done to show this or that. That's not writing. That's not scientific literature.
As a senior author, you've mentored many medical students and residents and young faculty. What is your approach to teaching and mentoring during the writing process?
So I think it's important to give some guidance, but not too much guidance. So many drafts, the first draft comes and I look at it and I try to be specific about where it can be improved without rewriting the entire draft myself, and allow the resident or the student to go through the learning process of assessing what I have to say and then making it part of the abstract without me writing the abstract. Yeah. Because that's how the mind works. That's how they will have to work as writers and authors. Obviously, I'll give more help and assistance to a medical student than I will a junior resident, and more to a senior resident than a junior resident, et cetera. But I really think it's important that they go through the thought process of seeing what I think about what they've written and translating that into a better written page.
You've published a lot of articles in high-impact journals, including the JTCVS. When do you know that you have something good that's worthy of shooting high?
I think the easiest answer to that, Brian, is what its citation, how I predict its citation value to be, which includes, in my mind, overall reader interest. How many downloads will this translate into? How much discussion will this be? Now that there's social media, will it make it into the social media? But the real currency for me is what I predict the citation value will be, so that how does it impact future studies? And if I think it's going to impact future studies in a large way, I predict a high citation value, then that's how I know to shoot high. Now, how do I predict that? It depends on the study. Depends how revolutionary the study is. Clearly, our first studies in thoracoscopic lobectomy that showed some major difference. This, now we've demonstrated a difference. You can see something between those two procedures, that they're different. Those were more exciting than the ones that we showed. Oh, it's a little bit, something else is a little bit different, or something else is a little bit different. Those were exciting papers to write because we knew it was going to have an impact.
Great. I'd like to pivot a little bit to your experience as an editor. You served for many years as an associate editor at the JTCVS. You have a similar role now at the Annals of Surgery. So I just want to talk a little bit about your experiences and impressions as an editor. Starting with, what do you enjoy most about serving as an editor for a journal like the JTCVS?
So I enjoyed the observational part. What are people thinking about? What is being written by other authors, good or bad? What are new topics that haven't, I certainly saw AI come in submissions to JTCVS before I ever saw it in any publication. You could see that coming as an interest, and so other topics similarly, you can see that coming. You're testing the scientific waters both nationally and internationally, and it's very it's interesting and it's educational. So I definitely enjoy knowing things before other people knew them. But I also enjoy critiquing work to try to make it better, even if it's not my work. One of the things that was most important to me was that I was the net. You know, when I was an author, if something was a little off, the reviewers might catch it. You know, it wouldn't go into the publication wrong. It wouldn't mean that I wouldn't try to make it perfect before I gave it to the reviewers, but other people were going to look at it outside of my narrow frame. You could read your own article 27 times and miss something obvious, and then someone else reads it once and they say, "Oh, no, this is clearly not what you meant." And so you knew that would happen as the associate editor or even the reviewer. That's it. That's our job. And I took that job as associate editor very seriously, both to read the paper myself as well as to read all the reviews, because we're the net. If we don't catch something, it gets put into publication, it becomes fact, and then if it's an obvious error, it makes all of us look bad. It makes JTCVS look bad, and it makes the association look bad. That responsibility is real.
Yeah, I agree with you. It's a real responsibility to the field. These articles become history, and it's the job of an editor is not easy, especially when you have disparate reviews. One reviewer loves it, one reviewer hates it. What do you do with that?
Right. Fortunately, that doesn't happen all that often, and I think it's because I took the responsibility of choosing the reviewers seriously as well, and not to choose reviewers that all are going to think the same, but choose the reviewers that I know are going to review it carefully and do the work that needs to be done. And most of the time, when there were disparate reviews, one reviewer just didn't get it. It wasn't because one reviewer found something. It could have been that no one else in the world would have found, but that one reviewer just missed something. And then that's easy to sort out. What's more difficult if you have one reviewer thinks that something is extremely important and one thinks it's trivial, and then I have to sort out what is the reader gonna think? What's good for the reader? Is this going to improve our knowledge? Is this going to improve our clinical care? Is this going to be discussed? Is this going to be downloaded? Is this going to be cited? And if I go through that process, usually I can sort out whether it's good for the journal or not good for the journal.
When you read all these reviews, what is it about a review that would make you think, wow, that was an outstanding review, a very thoughtful review?
Well, I think if the reviewer, first of all, the reviewer has to get it, understand the study. But if the reviewer can find errors in conclusion, here's the data, right? The statistician decides to do with the data what they want, but it's the author's job to take the data and say, based on these findings, we should believe X, Y, and Z. And some authors go too far. And it's the job of the reviewers to make sure that there aren't conclusions drawn that haven't been proved by the findings.
And if you had a resident that told you that they were interested in one of the most coveted positions in academic thoracic surgery, I think, an associate editor of the JTCVS, how would you advise them?
Start reviewing. I was at a resident luncheon earlier today where we were talking about how different careers in academic surgery start, and I asked them, how many papers have you reviewed? And these are relatively senior level residents, and most had not reviewed any. I said, do you think that when you graduate and you're an attending, you go from I've never reviewed a paper and I don't know how to do it to all of a sudden I can review a paper, I can interpret the literature. And so I encouraged them to, and I told them how to do it, to get access to reading and reviewing papers at an early level in their career, and to build that up. So if that's what someone wanted to do, they wanted the associate editor position, or to have that experience, you have to review. You have to learn how to review. You have to review yourself, and when Dr. Patterson writes back and gives you the judgment, you have to read the other reviews and see how your review fit in. Did you miss anything? Could your review have been better? And to take that knowledge into the next review.
And as an editor, I imagine you invited these residents. You gave them an opportunity.
Absolutely. Yes. I start with the students.
Yeah.
So I'll give a student a review and say, I'm going to do my review. You do your review. I'll submit mine. You take a couple of weeks to do it, because I usually don't take a couple of weeks. And when you're ready, we'll review it, and then I'll show you what the other reviews said when they come back. And if they are interested in it at that level, they'll continue to do it throughout their residency.
Great. Well, for the last few minutes of this conversation, I was hoping to talk about surgical innovation a little bit. And I would submit that you're a quintessential surgeon innovator. You are widely regarded as a pioneer in minimally invasive thoracic surgery that has nothing less than revolutionized our field. But there was a time when there was a lot of skepticism about thoracoscopic lobectomy. And you were an early adopter and developer. How did you navigate that early skepticism? How did you know that minimally invasive, complex pulmonary surgery was a necessity for the field?
Well, that was a difficult time because there were so many experienced surgeons who had more experience than I, who didn't think it would be an advance and were discouraging about the process, but that's true in any innovation. And so our confidence that it was going to be an advance was based on our ability to get funding for a study through the CALGB, the Cancer and Leukemia Group B cooperative group, and this we consented patients for this new study, this new procedure. We told them we had a certain amount of experience with it, but we didn't want to go further until we had more experience. And we described what would a thoracotomy be, what would our minimally invasive surgery be. So our first experience with this new procedure was consented, it was prospective, it was multi-institutional, and then we had data upon which we could then say and present, here is the data of multiple surgeons, not just me, in multiple institutions, not just Duke, doing a procedure that seems to have promise and can go further. And it was the cadre of us who were most interested, me, Scott Swanson, Todd Demme, and others, Rob McKenna, I don't want to forget any names, who believed in it and did the study and took it forward. And then the momentum from that, once we could get other people interested, they would do it. More studies would come from that. And it was the studies, many of them that were in the Journal of Thoracic and Cardiovascular Surgery, on pulmonary function, on pain, on return to full activity, that demonstrated the benefits of minimally invasive surgery.
Yeah, I think it's an interesting observation that many of the leaders in our field in minimally invasive thoracic surgery didn't learn minimally invasive thoracic surgery during their residency. They learned it as an attending, right? So I guess the next level of this question is, for a practicing, let's say, cardiothoracic surgeon that wants to learn a new procedure that they may not have done before, but that's an established procedure, let's say thoracoscopic lobectomy, how would you advise them to approach that?
It's a great question. It certainly does depend on the complexity of the procedure. What we did was give courses 4 times a year. Come to Duke, here's the didactic part, come and do this tissue lab, not an animal lab, but a tissue lab. We'll teach you how to do it, and then come back to us and watch us operate. Here's how it looks on the video. Here's how it looks with the tissue. You learn how to use the instruments. Come back and watch us operate. See how we set up the patients. See how we make the incision. See the conduct of the procedure in a video that isn't edited, obviously. See what the difficult parts look like. See what the easy parts look like, and that's how that generation of surgeons, many of which learned how to do the procedure. And we thought that was safe, ethical, and successful.
And then maybe another level of this question is, if you were today to develop or get wind of a new procedure, a brand new procedure that you felt in your bones will revolutionize our field further, how would you approach that?
Well, that's great. I'm looking right now. I look all the time. I am a very serious student of innovation, and I believe that too many surgeons are on the wrong side of the Rogers adoption curve. Too many are beyond. I think we, as surgeons and scientists, we should be at the worst early adopters. Late adopters, okay. None of us should be laggards, right? We're scientists. But I think I would do something similar. I would find, does this meet a gap? Is this going to be better, or just a different way of doing something that no one's done before, but really isn't any different? So is this better? Is it possible that it's going to be an advance? And if it is, then how best to learn the procedure in an ethical way? Patients shouldn't be experimented on, obviously. And then if I was able to learn it, could I prove that it was better? And then once I proved it was better, that how best to teach it to other people, ideally in a residency training program. But I think that we're all laggards. Even when thoracoscopic lobectomy was proved to improve pulmonary function, length of stay, pain, it wasn't required by the ABTS for training practicing surgeons. It took a while for the ABTS to catch up, and probably for good reasons, but it takes a while to get it into practice, to get it accepted and get into practice. But you got an idea for us to try?
Yeah, I do. I have a couple of them.
Okay, let's go.
Well, listen, Dr. D'Amico, thank you so much. This was actually really fun. I think you're a very humble leader. You have a storied career that many young surgeons really aspire to, and you've transformed our field. So just leave us with two final thoughts. What drives you the most about academic thoracic surgery, and then what, if any, philosophical tenets have guided your career?
So I think what drives me, what I tell the residents, is we got to be better every day. When former trainees come back and watch me operate just for fun, they'll say, "That's not how you do that operation." And I said, "That's how I do it now. That isn't how I used to do it." And so I try to look at my own practice, my own procedures critically. Is there any step that can be better? Is it more efficient, safer, easier to teach? In any way better. So try to make it better every day. And I think as a closing philosophical thought, we are so lucky. We're so lucky to be in positions where we have the opportunity to operate, train residents, make an impact on our patients, and write about it, and then make it better for the next generation. So this is such a fortunate position to be in as a thoracic surgeon in the United States.
Thanks, Tommy. That was great.
Thanks, Brian.
Okay.